thank you for the invitation to come to Duke. I seem to have been making many trips to American universities in the last couple of years, but I have to say this campus must surely rank as the most pretty of all the campuses that I've visited. I'm hoping that I'll get some time out from my very busy program to go and walk around the famous gardens that I've only seen from a car several times today. But thanks for coming.
John says no.
No? Well, thank you very much for coming. And what I'm going to try and do is I'm going to, in the next 40 minutes or so, really try and present to you a bird's eye view of the field of global mental health. And in doing so, hopefully convince those of you who may not be convinced so far that mental health lies at the very heart of global health. And I'll show you why. Initially with some evidence, but later on by going towards the very heart of the definition of global health and reminding you that at that heart, the way global health differentiates itself from international health is by championing equity over everything else, and why, in fact, mental health, therefore, is one of the most important disciplines within the global health agenda. Now, different people have different ways of starting their story of global mental health, but I want to start with this man here. Those of you who are psychiatrists, this is the sort of question you might get in your residency exams. Those of you who are not, this is a German psychiatrist, Emil Kraepelin, who is considered by many psychiatrists as one of the founding fathers of the biomedical discipline of psychiatry. And like many psychiatrists from that period, colonial psychiatrists who visited the colonies, he carried out observations of what mental illness looked like in people, the natives, as it were, of the colonies. And these observations that I've quoted from here on this slide were made in the hospital in Java, the mental hospital in Java. And I'm going to read out a couple of sentences from this quotation, which I think are very valuable and important from the point of view of the foundation of global mental health. So he was looking at the clinical forms of psychosis, what he called dementia precox in those days. And what he remarked is that of the numerous forms of dementia precox encountered amongst the Javanese, not one of the symptoms common amongst Europeans was missing. And I think this is a fundamentally important observation. But they were all much less florid and less distinctively marked. Now, work by people like Kraepelin and medical anthropologists in different parts of the world about 100 years ago and carrying on for several decades after that really laid the foundation, I think, of global mental health. As it happens, there were two academic traditions that seemed to operate pretty much in isolation from one another. In fact, I would even suggest to you with some degree of hostility and suspiciousness of each other's work. So the emic approach was championed by medical anthropology, and this approach really argued that mental health problems were so deeply influenced by culture, language, etc., that one could not apply classifications and nosologies from one culture to the other. One had to really embed oneself in that culture to really understand mental health problems. The etic approach, on the other hand, was heavily influenced by biomedicine. And what this approach argued was that mental illnesses were just like any other health condition, fundamentally biological conditions that were still awaiting the discovery of the precise etiology, but nevertheless they were fundamentally biological conditions, and therefore models of understanding mental illnesses that had emerged in the Western world could be applied, perhaps with some tweaking, in the developing world or other parts of the world. And these two approaches really seemed to emerge and then carry out its work for nearly 100 years in relative isolation from one another. I was profoundly influenced by the writings of two scholars, Roland Littlewood in University College London and Arthur Kleinman, initially in Seattle and then in Harvard. Both of these individuals in the mid to late 1980s wrote these two seminal papers in the British Journal of Psychiatry in which they called for a resolution of this dispute between the emic and etic approaches, and pointed out that both these approaches actually complemented each other. And there were strengths, both in the cultural anthropology approach as well as the biomedical, clinical and epidemiology approach, that in bringing these two together, we would actually be able to really advance the field of mental health from a cross-cultural perspective. And they called for really a merging of these two methodologies and emergence of what they call the new cross-cultural psychiatry. The key findings of the emic and etic approach, for me anyway, are summarized on this slide, and quite interestingly enough, they look exactly similar to what Emil Kraepelin wrote 100 years before. That the major categories of mental disorders were identifiable in all cultures and shared similar core psychopathological features. There was no doubt, though, that cultural factors influence various aspects of that mental illness experience, but the same thing could be applied for pretty much any health condition, perhaps a bit more for the mental health experience. For example, how these experiences were expressed, how they were acted upon, and indeed also the influence of cultural factors on course and outcome. Now, I think at this point, it's important for me to pause and remind myself, and perhaps some of you here, that there have been raging debates in this country in the last couple of years in particular about the seeming medicalization of everyday miseries by a psychiatry that it seems is increasingly dominated by, and worryingly enough, occasionally corrupted by the pharmaceutical industry. So there are concerns about, I remember one writer writing in the New Yorker recently about the Americanization of mental illness, talking about mental illness in the global context being, as it were, corrupted by pharmaceutical companies. Now, there's no doubt that one should be very concerned about the boundaries between everyday misery and depression and anxiety, but under no circumstances should we allow those disputes to minimize the suffering of mental disorders in the developing world. It's extremely important for us to remember not only that this rich body of evidence has clearly demonstrated the cross-cultural validity of major categories of mental disorders, but perhaps more importantly, that mental illnesses have been recognized and described even before biomedical psychiatry existed, and certainly before America as a nation existed. So I think it's very important for us to be clear in our minds that there is no dispute about the existence and the broad classification of mental disorders across cultures. And this is a very important foundation for global mental health, a very important foundation on which all other evidence has been built. So what are the other scientific foundations? Once we get past this dispute, do mental illnesses exist in other parts of the world, in other cultural contexts, and do they look similar? We are then able now to advance the field forward. And I identify 4 very important strands of science which I think lie at the heart of this new discipline. The first is the social determinants of mental health problems. As you know from the global health context, there's often been a great priority that's been placed again on the equity idea. The idea that those conditions that affect the poor in a more, are disproportionately affect the poor, or affect people in poor countries disproportionately, are those conditions that need to be prioritized. And in that context, mental illness has often been seen as a low priority. It was only in 1995, I think, that for the first time an effort was made to synthesize the evidence on the social determinants of mental illness. This was a very important report produced by Harvard Medical School and the World Health Organization that sought to demonstrate how mental illness was a development issue, that it was fundamentally associated with some of the core problems of developing societies, such as conflict, disasters, inequitable development, gender-based violence, and so on. These core concerns of global development were profoundly influenced by and influencing mental health. More recently, I think most of you in the global health field will be familiar with this very important initiative of the World Health Organization, the Commission for Social Determinants in Health, which sought to synthesize the evidence on the social determinants of health problems. You notice here I'll be using the word gap in 2 different contexts. In this case, the gap that is referred to in the title of this report, of course, is the health disparities gap, the gap in health outcomes and well-being between those who are usually at the upper end of the social class ladder and those at the lower end of the social class ladder. And they call for closing the gap in a generation through, obviously, predominantly social policy initiatives. I was asked to synthesize the evidence, to update the evidence from the World Mental Health Report, along with a team of other epidemiologists and social scientists for mental disorders. And what we were able to demonstrate was that social disadvantage and mental illness co-occurred in such a way that people who lived in conditions of social disadvantage were more likely to develop mental illness. And once you had a mental illness, you were more likely to slide into social disadvantage, creating a vicious cycle. So a complex bidirectional relationship between poverty and social disadvantage and mental ill health. The second important platform of evidence was the demonstration of the burden of mental disorder. For this, we must thank Chris Murray, Alan Lopez, and his colleagues for inventing the metric of the DALI. I think most of us here would be lying if they knew how it was actually cooked up. But nevertheless, it's been very useful for the field of psychiatry, for global mental health, because by combining the impact of a condition, health condition, on survival and years lived with disability, you were able to actually create a metric that one could then use to compare the relative burden of different kinds of health conditions against one another. And when you did that, you found that the overall burden that was due to neuropsychiatric disorders, this should be neuropsychiatric disorders, this covers all brain disorders from childhood to old age, was about 13% of the total burden of disease, the global burden of disease. And this is the countries of the world classified according to their income category status. And what you can see here is that the proportionate burden rises as the country goes from low-income countries to high-income country status. But even in the poorest countries of the world, for example, Sub-Saharan Africa, fully 10% of the total burden of disease is due to disorders of the brain. Now, this is a good EPI student, EPI exam question. Some people mistake this to reflect a rising prevalence of mental disorders. Of course, it isn't. This is a pie chart. This is a rising proportion of the total pie of the burden of disease. And of course, the reason why it is rising is because nutritional and infectious disease causes become less common as countries have an economic and epidemiological transition. So that's very important for the country I live and work in, India, which graduated from being a low-income country to being a low-middle-income country 2 years ago. One would expect then that yes, India continues on the path of its transition, that the proportionate burden of mental disorders in India or countries like China, Brazil, and South Africa will also show a similar upward incline in the years ahead. Now, it has to be said that for most global health policymakers, the DALI means very little. I think, to be fair, mortality and survival remains one of the most important drivers of global health decision making. And one must admit that mental disorders do not kill in the same sort of way that infant diarrhea, pneumonia, or indeed a whole range of other childhood health conditions, and in older age conditions like heart disease and cancer kill. But there is one demographic group in which mental disorders do kill. In all parts of the world, that demographic group, of course, is young people, people aged between 15 and 30, people who you would argue are potentially the economic engine of every society. In this particular demographic group, suicide and injuries linked to risky behaviors are the leading causes of death in pretty much all parts of the world. Here's some astonishing news, yet to be published, but it will be published in the months ahead. You all probably know that maternal mortality is one of the leading global health priorities, and nowhere is it a bigger priority than in South Asia, which is the epicenter of maternal deaths in the world. Well, last year, the Nepalese government released a report that showed that young women were more likely to die of suicide than maternal causes. This is an astonishing fact. In India, the latest evidence from the Million Death Study, as this is a study that I've been lucky enough to chair the Suicide Advisory Group, already suicide has overtaken maternal causes as the leading cause of death of women in India, both rural and urban, in more than 2/3 of India. And the way trends are progressing, suicide will become the leading cause of death of women in that country. Now, of course, we all know how important maternal mortality is. We also all know how low on the agenda, if at all it's on the agenda, suicide is. And it strikes me a little odd that we should not be concerned about avoidable premature deaths of young women, irrespective of the cause. And I think this is something worth considering about why we seem to prioritize some cause of death over others. Now, the third important plank of evidence is the treatment of mental disorders. Now, this is very important. Up until even as recently as 2001, when the World Health Report, which was focused on mental health, was released, there was actually very little evidence about whether we could treat these burdensome conditions in low-resource settings and with cost-effective treatments. The Disease Control Priorities Project, which I think many of you will be familiar with, the second edition, had a very extensive analysis of mental disorders. The mental disorders work itself, which included myself, was led by Steve Hyman, who was then with NIMH. And we looked at the cost effectiveness of the treatments of 4 groups of mental disorders. Alongside the mental disorders chapter, there were also similar analyses carried out for neurological disorders, drug and alcohol dependence disorders, and developmental disorders in childhood. In summary, we were able to show that in fact the treatments for these conditions were just as cost effective as other chronic conditions, including two of the most important global health priority conditions, HIV/AIDS and diabetes. Typically, for treating mental disorders, what you needed was a package of different treatments, just as you would expect for any chronic condition, that typically comprised of a combination of an off-patent psychotropic drug, brief psychological interventions, and social interventions delivered in a step care model. And anyone who's familiar with any chronic disease management program, you would recognize that this could easily look, the slide would look almost identical if one was dealing with hypertension or diabetes, or indeed a whole range of other mental health conditions. So far, the foundations of evidence that poverty and mental illness co-occur, and people who live in social disadvantage are more likely to suffer mental illness. Secondly, mental illnesses kill young people and disable people across the life course. Thirdly, you can treat mental illnesses with cost-effective treatments. However, there is a big challenge. How are we going to deliver these cost-effective treatments? Now, this chart shows the distribution of 4 groups of mental health specialists. Again, countries of the world are divided up according to the income category. And if we just take one group of specialist psychiatrists, you will see, what you can actually see on this slide is less interesting than what you can't see, which is the bar for the poorest countries in the world, when scaled against the richest countries in the world, barely appears on this chart. What this tells you is the huge iniquitous distribution globally of mental health specialists. Now let me try and convert this into actual numbers to give you an idea of the human resource challenge. This country has about 300 million people. It has about 50,000 psychiatrists. India, the population of India was revised last week by the census. It's crept up to 1.2 billion people. There are 3,000 psychiatrists in India. There are more psychiatrists trained in India who practice in this country than there are in India. That is a reflection of the sort of enormous challenge of specialist human resources. The bottom line is, of course, that we're not going to actually achieve much by emphasizing a specialist-led care model of mental health care delivery as has been done in rich countries. Neither is it available at the moment or accessible, and it certainly won't be affordable for the foreseeable future. So, how do we proceed? Well, since in the last 7 or 8 years, some of the most exciting evidence in this arena has arisen from the efforts that people have tried by using lay people to deliver mental health care interventions for a range of different disorders. And this evidence has shown that using lay people is not only safe, but it is effective. Of course, we call this star shifting. It's been championed in many areas of global health, not least HIV, AIDS, and maternal health. And now we have very robust evidence that star shifting can also be effective in the mental health care field. Just a few quick examples of some of the more important trials of star shifting and evaluations of star shifting. 2 trials from rural Uganda, one in an area where HIV seroprevalence was above 10%, and another with refugees living in young people who were refugees in camps in northern Uganda, using interpersonal therapy, which up until this first trial was published, had only ever been used by mental health specialists for the treatment of severe depression. They were able to train lay people. This is a group in session. Now, one very important thing to notice in this group, plus in some of the slides that follow, is that you can't actually tell who the provider is and who the beneficiaries are. This is, of course, because the provider and the beneficiaries all come from the same community. These 2 trials from Chile were targeting women in poorer neighborhoods of Santiago City. The first trial was with women attending primary healthcare centers. The second trial was women who were mothers who were depressed. It was a maternal depression trial. The interesting thing about this step care intervention was, first of all, what you can see is a behavioral activation group in progress in the primary health center. A couple of very interesting things about this trial. Firstly, that the women who became providers were originally themselves women who were depressed. So this is an example actually not only of lay people, but actually people who are service users becoming service providers. And the other important thing about this trial is that this program has now become Chile's national depression program. So this is a good example of an intervention going to scale in a country. This is a trial I'm very fond of for many reasons. Firstly, of course, because it comes from the region that I live in, but very importantly because the intervention was provided by the maternal health workers as part of Pakistan's national maternal health care program. These are lady health visitors. Many of these women who are lady health visitors, their primary role is really antenatal care and perinatal care. These are women, many of whom have not completed school, so many of them are not literate. About 60% cannot read and write. And yet, they were able to use a very simplified version. I'd call it CBT-derived interventions. It's called the Thinking Healthy Project, to effectively treat postnatal depression. This is the largest trial of postnatal depression in the world. In fact, it just goes to show what you can do in the global context. More than 900 seriously depressed mothers were randomized here. But another very important reason why this trial is interesting is they were able to show that the babies of those mothers in the intervention arm did better than the control arm, demonstrating perhaps for the first time that when you treat maternal depression in the developing world, you actually also see benefits on the babies. For example, the babies were more likely to be immunized, they had fewer episodes of diarrhea and respiratory tract infection. So profoundly important trial from a global health context. These were not randomized evaluations, but they were controlled evaluations now on another disorder, schizophrenia, in India, using, again, community-based lay people in a community health worker format to provide community-based rehab for people with schizophrenia, very, very enduring and disabling condition. We're very lucky. The Wellcome Trust has supported a randomized control trial evaluation. We've just completed recruitment, and hopefully we'll have the results out of that trial by the end of the year. Similarly, another trial for dementia. This one won Alzheimer's Disease International's prize last year for innovations in community care for people with dementia. Here, this is the community health worker, again a layperson who is trained to provide dementia support to families that are affected. Interestingly enough, the intervention showed not only benefits to the caregiver, but also showed reduced mortality of the person with dementia. We think that is because it enhanced adherence with other very important medical treatments, such as for blood pressure, which is a very, very important risk factor for dementia. And the last trial that I spoke about a little bit earlier today to the class the class that I taught. This is the largest trial in psychiatry in the developing world, involving nearly 3,000 individuals with depression and anxiety, where we were able to show quite large improvements in recovery rates for people with depression attending public primary healthcare centers. And in this picture, you really see task shifting, the essence of task shifting. The woman on the left here is a lay health worker, a lay health counselor recruited from the local community by the primary health center in which she's based. And the one on the right here is a psychiatrist who's visiting once a month. And I think the important message here, of course, is that task shifting only works when it is actually led by, supervised, and supported by a mental health specialist. But in this particular model, this lady here can visit 20 primary health centers each month, and so you can immediately see how the coverage that she can actually achieve is vastly expanded through the availability of the frontline lay health worker in the clinic. This is the sort of, Michael mentioned I've had a strong belief in community health workers. I have to say I come from a country where, the belief in community health workers is very, very long-standing. So there's a very rich history of using non-professional health workers in India for delivering care. And I was inspired by watching people like the Aroles, I know somebody here knows the Aroles, the Abhay Bang and others, who have been championing the use of non-specialists to deliver healthcare for maternal health problems and so on. And before any of the evidence was available, I wrote this book Where There Is No Psychiatrist. I'm really glad the trials came and proved my point, otherwise I'd be embarrassed. Anyway, the book seems to have actually found many takers in many different parts of the world, and now I feel more confident advocating the book now that I have trial evidence to support it. The fourth important pillar, we don't often think about discrimination and human rights as a scientific pillar. But there have been colleagues in London, the Indigo study, led by Graham Thornycroft from our partner institution in the Center for Global Mental Health, that looked at the pattern of discrimination amongst people with schizophrenia in 20-odd countries around the world. The truth of the matter is, of course, if you ask anyone who has been affected by a mental illness or is a caregiver of someone with mental illness in any part of the world, the chances are you will hear stories of hidden suffering, of shame, and of systematic discrimination in every aspect of their lives, whether it's in school, the workplace, the community, perhaps most tragically, even in the healthcare institutions that were built to care for them. We were reminded once again about the horrors that are perpetrated in mental health care institutions. In 2003, when unusually the Time News magazine decided to do a cover story on mental health in Asia. I say unusually because mental health care is hardly a great news story, except that in this particular case, the news story was about the appalling conditions of hospitals in South and Southeast Asia, most of, actually pretty much all of which were built during the colonial period, and which were really like human warehouses, places where people were essentially locked away and forgotten, decrepit institutions where even basic humanity and dignity had been abandoned. But that these institutions continue to operate today was the shocking news that this magazine reminded us of. Soon after this, Arthur Kleinman, Benedetto Saraceno, and myself wondered whether this particular story was just good news. You know how it is, you pick the worst example to sell a good copy. So what we did is in 2003, after the story was published, we started approaching human rights groups, news agencies, and a variety of other people who started contributing images. And we started building up a photo archive of mental hospitals and the care of people with mental illness in the community. And I'm not going to show you many images, I'll just show you a few samples of images. The reality is, to our great dismay, we discovered that this was in fact not an aberration. This was in fact the rule. This is an image, for example, of a hospital for intellectually disabled children in Asia. This is an image of a hospital in Eastern Europe, of course, where some of the worst horrors of psychiatric institutions continue to be perpetrated. And mind you, these are all images taken in the last few years. These are not from 100 years ago. This image is, of course, particularly harrowing because you can see they've not even bothered to put basic crockery and cutlery in this hospital ward so that man has to drink water out of a pail. And this image was sent to me yesterday, just as a reminder how everyday these abuses are. This is an image from a hospital in West Bengal in India where 14 people have died in the last month of malnutrition. And actually, what you can see is a nurse. And I don't know what you can the guy who sent me this picture, we have a submission portal. People submit these images, which we then use for human rights advocacy purposes. I don't know if you can see this lady, she's a nurse. And what she's carrying in her hand, she's carrying a wooden rod. This wooden rod is used to beat patients with mental illness as a form of discipline. Restraints are commonplace in mental hospitals, and the restraints are not just physical. The restraints are also chemical, where people are routinely sedated with massive doses of drugs as a way of simply keeping them quiet. Now, it's not surprising if this is what's going to happen to someone you love when they have a mental illness. You're unlikely to actually take them to a mental health care institution. But sadly, we also know that many mental health care problems lead to great disturbances in behavior at certain phases of the illness, and people struggle in the absence of any community mental health care system to manage their loved ones. This image was taken by Agence France Presse. It shows what a landless laborer family in North India has contrived to protect their young son with schizophrenia. So they basically put him up in this wooden box when they go off to work in the morning in the fields, just so they can be sure that when they come back, he's still actually going to be there and it's going to be safe. I promise you this is the last image because this could go on. There are tens of thousands of images like this, all taken in the last few years. This is an image from our program in the London School. We have a program evaluating community mental health care programs in Africa and Asia. What I really want to point out is this image of this hand here. This picture was taken by my colleague Alex Cohen on a visit to a home in the Philippines. This is a 24-year-old woman who has spent 4 years behind that door. She has schizophrenia, and we know well enough that people with schizophrenia don't need to live like that. The good news, of course, is that after the program run by a faith-based organization was put into place, that woman actually did emerge from that room and is now, to the best of our knowledge, being rehabilitated in the community. What really astonishes me is that for a moment, just imagine if even one of those images was a person with HIV/AIDS. Just for a moment, imagine that. Or imagine whether that was an image of Abu Ghraib prison, which I'm sure many of you will remember. And you will all remember what an incredible global outrage there was. There was front page news in every country of the world. If anyone with HIV/AIDS had to suffer that even half the indignity that you've just seen, there would be global outrage. But there has not been a word, not a word of protest, embarrassingly, not even from the psychiatric community, about what is going on in the name of psychiatric care. Something that Arthur Kleinman wrote, I think very movingly, and he's right, as a fundamental failure of humanity, that we cannot feel compassion for people with mental health problems. But even when people do seek health care, the kind of care they receive is terrible. Not just mental health care, but physical health care as well. We know fully well that if two people walked into an emergency room anywhere in the world with exactly the same chest pain, exactly the same demographics, but if one person had schizophrenia and the other person did not, we know fully well who is going to get offered the whole medical option of revascularization and who's going to be sent home with nothing. It's not surprising then, of course, that people with mental illness live on average, they have half the life expectancy than people without. In Mozambique, where I worked as an advisor to the Ministry for several years, we were doing a needs assessment for the country's mental health policy development plan. And not surprisingly, we found a very high prevalence of childhood epilepsy and developmental disabilities, not surprisingly because these are conditions that are linked to poor perinatal care, but we didn't find any adults with these conditions. So one can only imagine what happened to these kids as they made their way through childhood. Beyond this particular scandal is the scandal of the lack of access to the cost-effective treatments. So this is there's no question that the images I've showed you reflect quality of care for a very small fraction of people with mental illness. These are people with the most serious mental illnesses and disabilities. At a larger global health scale, the true rights scandal is the right for people to access the evidence-based cost-effective care is missing for the vast majority of people with a mental illness, reaching an astonishing 90%. This is another kind of gap, the gap between the number of people who need care and actually receive it. In fact, it's pretty high in this country as well, but it's much higher in the poorest countries of the world, and the gap is equally high even for the most serious mental illnesses. It has to be said the gap in this country of 50% is for the more mild or common mental illnesses. At the more serious end, I think the gap is much smaller. It's this treatment gap and all the evidence that I presented to you earlier, particularly this very disturbing lack of any global health attention on this crisis. I consider one of a global health scandal on par with the unacceptably high rates of maternal mortality, which really spurred three of us to approach the Lancet in 2005. We knew the Lancet Medical Journal had been championing neglected issues in global health. It had done a remarkable job, some of you will know, with child survival. It had, through its focus on child survival, it had energized the field and a multilateral agency like UNICEF to look at child survival. We approached the editor really not thinking that we were going to get even a hearing. I remember writing an email to Richard Horton, suggesting to him that it was time for the Lancet to start thinking about mental health as a major neglected global health issue. And much to my surprise, within about 5 or 6 minutes, I got an email back from him. This is Richard's way of working, saying he wanted to meet very quickly to discuss this. And of course, that led to 2 years of hard work to synthesize the evidence that I presented earlier, and the publication in September 2007 of 6 articles in the Lancet focusing on mental health. This was the first time the word global mental health actually was used in any systematic way. And if somebody had to ask me where does the origin of this field lie, at least in the terms of these 3 words occurring together, I have to say it has to be Richard's thinking about sticking mental health and globe together, global, on the title, on the cover page of the Lancet. So there were 5 articles that synthesized the evidence, and it ended with a call to action that many of these series that Lancet publishers typically end with. And the call to action, as you can see here, is something that is intuitive. It really builds very, very well from the evidence that I presented to scale up the coverage of services for people with mental disorders in all countries, but particularly the poorest countries of the world. And then we call for the scale-up process to be based on 2 foundational principles, that of science, the science of cost-effective treatments, and an equally important principle of respecting the human rights and the dignity of people with mental disorders. And I want to finish off by looking at what has happened since 2007 and looking ahead on where this field might be going and why I believe that this is potentially one of the most exciting new disciplines in global health. There are three important actions that have happened since the Lancet series in 2007. The first has been the very important effort by the World Health Organization to synthesize a huge mass of evidence on treatment effectiveness, with a specific focus on the treatments that can be delivered by non-specialist workers in routine care settings. The MHGAP program is the World Health Organization's flagship program on mental health. And apart from, I think, the importance of why I think it has actually transformed our field in terms of giving us very specific tools that we can now advocate to ministries of health for scaling up, another very important and forward-thinking aspect of MHGAP is the combination of mental, neurological, and substance use disorders under one umbrella. I think this is a profoundly important step forward. Profoundly important because finally all these three groups of conditions that involve the brain have come together as they always should have been, at least in the global health context. They've done away with the disputes of territory that typically you would see in highly specialized contexts, and as far as I'm concerned, the field of global mental health encompasses all brain disorders and not just psychiatric disorders. And this is certainly the vision of the WHO as well, and we need to be taking on board neurologists, developmental pediatricians and addiction specialists alongside psychiatrists, psychologists, and social workers as being the specialisms that are relevant in the field of global mental health. 3 years of very hard work involving hundreds of experts led to the publication last year of the MHGAP Intervention Guide in the word of Dr. Chan, who launched it on October the 10th in Geneva. She calls it 100 pages of simplicity and wisdom, and it is truly 100 pages of wisdom. I think every psychiatric resident actually should look at this. It's beautifully laid out algorithms for community and primary healthcare workers for 8 groups of disorders, from childhood autism to dementia and old age. So we now have what Jeff Sachs always reminded us of in the mental health field, the bednet. The equivalent of a bednet, when he spoke at the launch of the Lancet series in 2007 in London, he said what the mental health community needed was the equivalent of a bednet. If we were ever going to get our agenda onto the global health agenda, we needed the equivalent, and I think MHGAP has given us the first solid set of tools that we can advocate to answer the so what question. The second is the continued efforts to build evidence to deliver what works, what we might call the implementation science or delivery agenda. As part of the Lancet series, we carried out a priority setting exercise about what might be the global mental health research priorities, and this was done within the context of scaling up. And not surprisingly, 2 major sets of questions emerged to develop and evaluate interventions for people with mental disorders that were going to be delivered by non-specialists. And for me, the most exciting work really lies in using lay people to deliver interventions. And secondly, how you can then scale up these star-shifted interventions within routine healthcare systems, for example, the maternal healthcare system or the HIV/AIDS care system. The good news is there is new funding. For those of you who are academically minded and looking for your next research dollar, there's some terrific news in the last few years. There have been a number of either new global mental health research funding opportunities or greatly expanded global mental health research opportunities. And these are not just in the traditional north. For example, the Sir Dorabji Tata Trust is the largest development funder in India, and believe it or not, this year in the strategic plan, mental health is the #1 priority for funding for the next 5 years. So this is unexpected, of course. It's a huge bonus for those of us who work in India. But this is an example. Atlantic Philanthropies is based in Hong Kong, and they too have got mental health way up there on their agenda for funding in China and Hong Kong. So it's not just the traditional donors in the north that are now prioritizing mental health, but a whole range of new donors in rich middle-income or relatively rich middle-income countries that are also showing interest. And the third important action is the movement for global mental health. And this brings me back to the point about not showing compassion, really asking ourselves, why do we not have compassion? Why is it that some health conditions create more compassion than others? I've thought long and hard about this, and I'm sure many of you who work in the mental health field have also wondered long and hard about it. Why does one form of suffering create more compassion than other forms of suffering? And certainly in the mental health field, in part it's because we are not comfortable about mental illness. I don't think we ever have been comfortable from times gone by when we associated mental illness with superstitious beliefs about witchcraft and bad spirits and karma, to contemporary times when we associate mental illness with bad choices in life, bad lifestyles, and bad behavior. I've been very inspired by the work that people with HIV/AIDS did to counter similar kinds of stigma, mind you, that people with HIV/AIDS suffered. The same kind of idea that it was your choice, it was your bad behavior, etc. You don't deserve our compassion. And yet, what a transformation there has been in the last decade in terms of access to care and a life with dignity for people with HIV/AIDS. And a lot of that, of course, is because of the Treatment Action Campaign in South Africa and the coalition that people living with HIV/AIDS formed with professionals and practitioners to stand together to call for a science-based scaling up of access to antiretroviral drugs and other forms of care. So the movement for global mental health was launched a couple of years ago. It seeks really to mimic the same kinds of strategies, or some of the strategies that the Treatment Action Campaign used. It's a coalition of professionals and civil society really standing together, sharing the same platform to really call for the rights for people with mental disorders to be respected. These are a multitude of rights, starting first and foremost with the simple right to freedom, which you'd think would be something that would be a given, but in fact it isn't. The right to inclusion, and of course the right to receive health care. The movement has grown slowly but steadily. It now has a secretariat that's based in Melbourne. It used to be de facto based in the NGO that I work with in Goa, but it's now based in Melbourne. It has more than 90 institutional members and more than 2,000 individual members. And I would suggest to you that if you want to find out more about the movement and you want to join up, it's only a mouse click of effort. This is the website. And you can also consider attending the Global Mental Health Summit on the 17th of October in Cape Town, where we will have a kind of a powwow really of people with mental illness, funders, researchers, all working together to talk about how to strategize and strengthen the importance of mental health in the global health agenda. So I hope, so far, I don't need to convince you anymore why mental health matters to global health. These are just a listing of the different reasons that I've presented you with in the last half an hour or so. And for those of you more interested to read more about this, you can look at our commentary in JAMA last year that describes why this field has come of age. But I want to return to the theme of equity. Global health, of course, is a fairly new invention of it's a new avatar really of what we once used to call tropical medicine a long time ago. That's what my institution is still called, or international health. My title is called International Mental Health. And people have tried to understand, how does global health differ from all these previous avatars? My colleague in India, Srinath Reddy, has a wonderful way of very perceptive interpretation of his own, and he says, international health is what what we in the rich north could do for you in the poor south. Whereas global health is really about what we in all parts of the world can do together to improve the health of all people who must live and share this planet of ours. Jeff Copeland and his colleagues, I don't know, Mike, if you were involved with this, he wrote this very important definition of global health in the Lancet a couple of years ago, and I think it's an extremely important definition for me because it really suggests why mental health is at the heart of global health. As you can see, the single defining feature in my mind that differentiates global health from its predecessors is its emphasis on equity, on health disparities. And of course, health disparities are both between country as well as within country. And it is the health disparities within country that I think are of the gravest interest to us, because these are individuals who otherwise share the same health system and should really have, therefore, similar health states. Now, typically when we think of equity in health, the classic fracture line that we are accustomed to think of is social class. People at the lower social classes live shorter and unhealthier lives than people at the upper end. But I would suggest to you, and I hope I've demonstrated to you, that there is a group of persons who, across countries, across cultures, across social classes, systematically have poorer life expectancies and poorer qualities of life lived than people without that problem, and that, of course, is people with mental health problems. And so if equity is a key driver of global health, then mental illness, it seems to me, is at the heart of the agenda of global health. I want to finish off by looking ahead at the future of global mental health. And I wanted, this is something, it's a new territory for me. I've always been an implementation researcher for all my career, but increasingly I have realized that we do have certain problems with our field. And those problems are to do with the lack of sufficient science in our field. It has to be admitted, in spite of all the positive spin I've given you so far, it has to be admitted that we do not fully understand many of the afflictions that affect the brains of people who then go on to develop mental health problems. We're nowhere near understanding the etiology of many of these complex conditions. We're certainly nowhere near as compared to our colleagues, say, in many other chronic disease areas. And it's also got to be admitted that our armamentarium of treatments are far from effective. Even if everyone got every treatment that we know works, we still would have a large group of people who will remain disabled, impaired, symptomatic. The honest truth is our bed net has some pretty big holes in it. And I think one of the reasons for that is that we have failed to really take advantage of the word global in global mental health. I think you're all familiar with the 10-90 gap. It's been well recognized. 90% of the world's global of health research spending occurs on 10% of the world's population. I suspect in the mental health field it's more like a 5-95 gap. That is to say, 95% of all the research dollars are spent on researching 5% of the world's population. That 5%, of course, lives in North America and Western Europe. And I would argue that given the complex nature of mental disorders, typically a very complex interaction between genetic and environmental factors, it's unlikely we're going to discover anything new by constantly researching the same 5% of the population that shares the same environment, social, cultural, genomic, etc. And I think one of the great excitements that I have about global mental health is to actually think of global as a way to actually spread out how we actually study mental disorders in different parts of the world in order to better understand mental illnesses. Another important aspect of global mental health to me would also be to spread out and understand how traditionally systems have used different forms of therapies to treat mental disorders. Let us never forget that mental illnesses have existed from times immemorial, and people haven't just stood around watching people fall ill until psychiatry came along. There have been traditional systems of care for mental health problems in every part of the world. Could it be that the equivalent of this herb, no, this is not marijuana, for those of you wondering what it is, this is artemisinin. Of course, this is, as I was talking to some of the students earlier, this is something that was known to the Chinese emperors way back in 200 BC as a treatment for fever, was rediscovered 40 years ago by medicine. It's, of course, now the first-line drug for malaria. Is it possible that there is lurking out there some forms of pharmacological or psychosocial interventions that we simply don't know about, but that have been used in cultural traditions in different parts of the world? I'm hoping very much that the grand challenges in global mental health, I don't know how many of you are familiar with this initiative. This initiative is being led by the National Institutes for Mental Health and the Global Alliance for Chronic Diseases. I'm the co-chair of the Scientific Advisory Board. I'm very excited by this initiative because it's backed by the world's leading research funders. Starting with the NIMH, the GACD comprises 8 of the world's leading research funders. Together they are 80% of all the research dollars in health in the world. The Wellcome Trust has also joined as a partner, and Autism Speaks has joined. We hope to release the results possibly by the summer. And what I hope is that the grand challenges will set the stage for a combination of both discovery and delivery research that can really greatly expand the agenda for global mental health, so that what we can do through this research is not only derive local lessons, local solutions, but which have global lessons. For example, I think task shifting is a good example, might potentially have very important lessons for rich countries that are struggling with reducing the costs of mental health care. We can generate evidence that not only helps in advancing health systems in developing countries, but actually fundamentally also helps in advancing science. And in doing so, really, the global health definition comes a full circle. That is to say, we do research around the world to benefit people everywhere. So therefore, in summary, to finish off, this is certainly my agenda. My primary work will, of course, always remain in the delivery arena. This is where I've spent most of my time, really working out solutions to scaling up the things that we know work in existing healthcare systems. But I'm also increasingly excited by the science agenda, the agenda of actually discovering causes and new treatments to improve the lives of people with mental disorders. And you can see that these are the programs that Mike had mentioned, that I should briefly mention the work that I'm involved with. These are all a range of programs that I'm involved with the next 5 years that really reflect my dual interest in both delivery and discovery. Premium is a new 5-year program that we've just launched a few months ago that is really aiming to map the psychological approaches that people have used in South Asia to manage depression and drinking problems. We're trying to evolve a methodology, as it were, to describe psychological treatment approaches, much like a drug discovery kind of pathway. And the hope is that we can tap into cultural knowledge, and in doing so we can hopefully discover approaches that we hadn't thought of before and then put them to test through randomized control trials. InSense is a major program that is working with 2 mental hospitals in India, the sorts of places you saw images of, in which we're hoping over a space of 4 years to transform these hospitals in a systematic, documented way into open institutions, which actually then become centers through which community-based outreach care is delivered using the models of task shifting that we are evaluating. Prime is a new 6-year program funded by DFID, the British government. It's an overseas aid arm that starts next month. This is working in 5 countries, Nepal, India, South Africa, Ethiopia, and Uganda, where we will be scaling up MHGAP treatment. So the treatments that MHGAP has advocated, this is implementation research through the routine healthcare system and the maternal healthcare system. These are the 2 healthcare settings that we're going to work in. Just last month, the Ministry of Health in India has announced the formation of a commission for mental health. I'm very pleased to be a member of that commission, and over the next 6 months, we'll be designing the framework for scaling up mental health for 1.2 billion people, entirely financed by the Ministry of Health of the Government of India. To me, this might easily be one of the most ambitious and large-scale programs for mental health that I'll ever have a chance to be involved with. And the last, and this is perhaps my smallest, but perhaps my the one that makes me happiest, is Empower. This is a collaboration that I've been very lucky to form with 5 user groups in South Africa, Zambia, Kenya, India, and Nepal. It's wonderful as a mental health professional who thinks that my work has been marginalized and I've struggled for a long time to actually meet people with mental illness, living in societies where stigma is rife, and to discover the sorts of challenges they've had to face. It's actually inspirational. It makes everything we struggle in as academics seem completely trivial. Nevertheless, these groups have joined hands with myself really to build a partnership between researchers and civil society groups to encourage there to be more dialogue between these 2 communities, in part so that my research thinking is influenced by their experience, but also that the research that we do influences the sorts of advocacy. So the idea is, this is an example of a poster that one of the groups has developed, develop communication materials. So, you know, from documentaries, films, songs. The Kenyan group, for example, is developing a song with the financial support we've received here in Swahili, which can be played on the local radio stations. I've got to end by just recognizing that at least my own work has been supported by many different funders. I have to say the most important one is the Wellcome Trust that has directly supported me for 17 years. And I think it's important to say the 17 years because I think this kind of work only happens when you have consistent long-term support from a funder, and I have to say the Wellcome Trust has really fulfilled that role very well. And the other big support for a long time has been the MacArthur Foundation here in the US that supported my school adolescent mental health work, also actually coming up to nearly 15 continuous years. Okay, I'll finish there, and thank you all for your patience. There was a video, but I think I won't show it because I think the sound system may not be working. Although I don't know if we can try it, but if it doesn't work, it doesn't matter. I'll leave the video here, which shows the Brazilian government's program to really marry science with justice by deinstitutionalizing people with mental illness. I don't know if you're familiar. In Brazil, for many years there was a system where the junta used to support private psychiatry. Private psychiatrists would run institutions, and once you got somebody in the institution, there was no incentive to charge them because you got paid an annual fee. The new government created a program called the Return Home Program, in which people were given money to return home as a pension, and that was combined with No, I think you play it.
Do you like?
Yeah, because the sound comes on. Yeah, it comes on after this. So this is a return. I don't know if the sound comes. Without music, Brazilian videos don't sound really as good as they do with music. So do you have a sound here? Anyway, I think we'll just take questions.
Okay, well, thank you very much. I don't need to get in the middle here. Why don't you just ask questions to Vikram? Just go ahead. Vikram, why don't you call on?
Yes, thank you so much. That's really wonderful. I'm wondering what we know about the efficacy of, given how few mental health professionals there are, how many languages and cultures there are, what do we know about the effectiveness of therapy, in situations where there has to be cultural and linguistic translation? And I'm thinking in particular of Devin Hinton's work in Cambodia. I'm thinking in particular of Devin Hinton's work in Cambodia. He spent 3 years there, and he was able to have a lot of impact on constructs of PTSD among even Pol Pot regime survivors. But he was there 3 years and he knew the language. So I'm just wondering what we know about the efficacy in situations where translation is really required.
Yeah, I was asked the same question actually earlier today by in the student conversations. So I think clearly, the examples I've showed you of the trials, for example, by the Johns Hopkins group in Uganda, are just reflections of that. First of all, it is possible. So it is possible to translate these, not just the language, but even the conceptual construct of, say, IPT, which emerged very much within the cultural milieu of North America. It was possible for them to translate that cultural, that framework to the very different milieu of Uganda. And my sense from them is that the key issue is simplified and adapted to the local cultural concept in a very systematic process of research, which itself is very important. Before you rush into doing randomized control trials, I think the need for doing very systematic, formative and pilot work to adapt these interventions is one of the most important lessons that I have taken away from my own work and from the work of others. It's interesting you asked me this question also because we're putting together a review for a journal called Behavior Research and Therapy, where we brought all the trial leaders of all the depression trials, in fact all the ones I've showed you, to actually analyze very carefully what adaptations were needed to CBT and IPT for each of their intervention, for each of their trials, and to see whether we can synthesize and draw certain lessons about two things. First of all, what are the universals? Because I actually believe that certain elements of psychological interventions are universal principles of good interpersonal practice in any realm, whether it's psychotherapy or good healthcare in any other realm. And then what are perhaps the specific areas, techniques, or strategies that needed modification, and in what way for them to be applied, not just in the different cultural contexts, but also in the hands of non-specialists. Because all these treatments were developed for delivery by highly trained mental health specialists, and a key issue is how do we, make them deliverable by non-specialists.
So at least in the U.S., a large percentage of people with mental illness are also homeless. I don't know if that holds true globally, but how much do you think, addressing the issue of homelessness belongs with neurological issues, substance abuse?
So yeah, it's very common. Mental illness and homelessness go together everywhere. It's not just in the US. But comorbidity, that is to say substance use and mental illness, that is contextually dependent. So it depends a lot on the local substances to begin with, and what the local, social attitudes are towards substances. So speaking in India, mental illness and substance use don't often go together as much as I've seen in Britain. So I think that it's homelessness and mental illness is very common, but not necessarily with substance use. The other thing in India is substance use. The most common substance is alcohol. You know, I mean, if you don't count tobacco, then it's alcohol. It's not so much sort of opiates or other sort of narcotic drugs that you might see perhaps in the West. Yeah.
Thank you for speaking with us today, Dr. Patel. So I've seen quite a few articles and talks recently about overprescription of mental health drugs in Western countries, especially in terms of depression-based drugs. Do you see with the future scaling up any potential worsening of this problem?
Yeah, there's a danger, and one has to be aware of that. I'll tell you, one of the things that I would suggest we should be thinking in our field is to dissociate depression from everything else. I think the discourse on depression has really confused a lot of people when we talk about mental illness. I think we have to first recognize that mental illnesses are very heterogeneous. And it would be equivalent to us lumping the common cold and lung cancer by saying we're talking about respiratory disease. I think it's time for us to recognize that depression is a gray area. There's no question at the severe end. You know, that's not the gray area. It's the sort of the milder end that then morphs into sort of everyday misery, which is the confusing end. And the use of medication and the diagnostic boundaries, these are all legitimate concerns. But I think there is everything else, psychosis, dementia, autism, etc., for which I don't think we have the same concerns to do as we do with depression. For some reason, I've never fully understood why the depression debate has almost completely colored every discussion about mental illness. It could be because it's the most common condition and there's so much money in pharmaceuticals. But from the global context, I'm always cautious about mixing, conflating depression as being the mental health problem. We have to be concerned, but I just want to add one more thing. The problem in developing countries is not overprescription, it's the complete lack of any prescription. So it doesn't, in most of Africa, antidepressants are not even available. So where's the question of overprescription? It doesn't even arise at the moment.
Thank you very much for your presentation. Question is about funding. You mentioned that you showed a slide of a lot of funders for mental health. I get the impression that in the United States, there's a lot of funding towards individual treatments, particularly biomedical medication, trying to understand the etiology of disorders, and not as much towards implementation, health systems research. So I personally feel that there are a lot of treatments we have that just don't reach enough people, especially in terms of equity. And so we should maybe invest more in that. I was wondering what you think of how the prioritization of research funds in terms of treatments versus implementation, what that looks like here or in other countries, and if you think that, see that changing, or do you have any ideas about how we should allocate our funds in that way?
Yeah, I was interested. I was at an NIH meeting a month ago on implementation dissemination research. They have a meeting every year on implementation dissemination research. I don't know if you ever attended them. So I was speaking actually on task shifting. I was invited to give a lecture on the global context of implementation research. First of all, I was absolutely amazed at how many people turned up for the meeting. 1,300 delegates. This was incredibly reassuring to an implementation researcher. And I also heard the same complaint from many people in the audience. They were not complaining to me, but they were complaining to the NIH, that about 5% of the research dollars the NIH gives out is implementation research. Clearly, this has got to do with the kind of vision the NIH has of what it considers science. And according to my colleagues in NIH who had invited me, apparently 5% was 5 times more than it was 10 years ago. So actually, it was all in the upward direction. But obviously, the balance still was heavily skewed towards science, what is seen as science, as opposed to implementation. I think the same applies for the research councils in other parts of the world. It's very similar. The place where implementation research is being championed is through bilateral and multilateral development agencies. So DFID, which is the UK's USAID, as it were, they will fund implementation research, but they will not fund basic science research. So it could be you need to be looking at USAID, for example. I know there are, in Johns Hopkins, they've received grants to work in the Congo on scaling up psychological treatments. So maybe it's a different kind of agency that will fund implementation work.
I think, Vikram, that raises a really interesting question. Maybe you could address a little more globally. So you're trying to create a movement which is desperately needed for a major global health problem. And if we try to sell the movement on the basis of the fact that we sort of know what to do, it's more a matter of getting it implemented. And we want a task shift, which means we don't need psychiatrists, we don't need psychologists, PhDs. How do you do that and at the same time get a global movement to bring in academia? Because academics are going to have MDs and PhDs, and they're going to want to get grants from prestigious agencies, not from bilateral agencies.
Yeah.
So hearing your talk, I'm just thinking, how can academia help you create this movement you want if academia doesn't feel, well, what you think needs to be done quite fits with academia?
Yeah, I think these are they're very important observations. Firstly, I have to say, psychiatrists and other specialists are essential because task shifting doesn't work without them. And I'm not talking about research, I'm talking about the clinical programs. So it's very important for me to emphasize this. This is not task dumping, it's actually reorganizing. Task shifting is always about reorganizing the roles of different people. It's not about saying you don't need such and you don't need that one. You need everyone, but you need to rationalize how expensive people's time is used in the most efficient manner. So I've been worrying about the same point that you made about how do we make sure that the larger community of professional scientists and practitioners who may feel alienated from the delivery agenda because that doesn't directly affect them, how they can be engaged. And that's where the discovery agenda comes in. I think the discovery agenda is fundamental for me. It's become increasingly crystallized in my mind that we know so little. I mean, obviously I can spin this in both ways. I can say we know enough that we shouldn't be sitting passively to do nothing, and that's the delivery agenda. But we also need to be honest and say we don't know everything, and there's a huge gaps in our knowledge. And there, the global opportunity allows us to discover new treatments and new causes. And in doing so, potentially, we'll also build research capacity in the global context that could also then answer the more relevant policy questions of the time. So I think you can actually achieve both objectives. As I said, the grand challenge is, it's going to be interesting. I can tell you, since I have an idea what they look like, they're a very fascinating mix of discovery and delivery. I'm very pleased, I have to say, because clearly, I think the challenges will bring the basic science community and the more clinical research community together onto the agenda, because some of the questions are, more discovery oriented. Asha, and then
I wanted to follow up on this, on sort of the research agenda and the fact that 90% of the research kind of is done on 10% of the world's population. And so that means that we have glaring holes in our understanding of etiology of mental disorders and the treatments. And I just wanted to hear your opinion about kind of where do you think the biggest kind of holes in our research are, kind of thinking globally, which conversely is sort of where do you think would be the most fruitful sort of place to kind of shine that research light if we were able to expand the research more truly globally, because we're obviously missing very important pieces of the puzzle.
So, the etiological research presupposes we know what the disorder is. Now, it'll shock you if I tell you that there has never been a phenotypic description of autism outside the Western world. Actually, we have no idea what autism looks like. We've just completed a systematic review on the epidemiology of autism. There is not a single epidemiological study from the whole of Africa and Asia. We not only do we know how common it is, we don't even know what it looks like. So imagine that. We are actually at ground zero with autism. We still don't know, is the phenomenology, the psychopathology that's been described here, to what extent does it look the same or different in other parts of the world? Can we have a universal, how can we have a universal diagnosis without ever there being a phenotypic description? So we're at that stage. Not even at the endophenotypes, we're talking about the clinical phenotypes of autism. With psychosis, maybe we're a little bit stronger ground. Depression, we're much stronger ground, I have to say. So I think with different disorders, we're at different stages. Starting with phenotypes, we then go to the next stage of biomarkers. Basically expanding the human participant base that we currently have at our disposal, which we're researching, to much larger segments of the population, Africa and Asia, for example, to study things like biomarkers and endophenotypes. This is where I think the agenda should go. Certainly the grand challenges certainly will pick up on this. I know that it is going to pick up on this. And that then what might happen is different funders will pick from that list what suits them. And it could be the NIMH will pick the more science agenda, maybe somebody else will pick the more delivery agenda, but we will hopefully then bring people together across the disciplines into the global health agenda.
Yeah, I'm just wondering what the research says about the prevalence and treatment of personality disorders across cultures.
Well, it's another good black hole. It says nothing at all because no one's researched it. I mean, I'm exaggerating. There are isolated studies. But very, very few. Which is why personality disorders does not appear on MHGAP, by the way. It's not one of the 8 conditions. And the reason is they had to make very important decisions about how to prioritize. First was burden, of course. Second was the availability of cost-effective treatments. So it could be there could be a very important condition, and borderline personality is one such example, but for which we do not have, at this stage of time, sufficient information on cost-effective treatments that can be delivered by non-specialists in primary health care. So obviously, not every condition could be included, and that again is part of the knowledge gap that we need to actually address.
What are some of the non-pharmacological treatments in this area of global mental health research that you think may be promising? This idea of looking at traditional therapies or cultures and what they have found effective in treating mental ill, particularly severely mental ill. I'm particularly interested in schizophrenia. And then another idea is that in some cultures, some of the severely mental ill are revered. They view it not so much as an illness, but as a rite of passage. And if they're getting the right guidance, they may be able to go, move through the psychosis and actually have a better insight or, a more depth of personality or life experience. What are your views on that?
Yeah, so I think these are 2 quite different questions. To answer your first question, what are the possible promising psychological approaches? So as you know, MHGAP has a very strong set of clear guidelines on psychological treatment, but they're all derived from the standard ones, CBT, IPT, motivational interviewing, and so on. So, there's no surprises in there, but the good news is that they have passed through the evidence synthesis process, and there's sufficient evidence that these can be delivered with some supervision in primary healthcare settings by non-specialists. So that's a very important statement that's come out through MHGAP. In terms of unknown treatments, I think that's what you're referring to, treatments that have been used in traditional settings. The answer is I don't know. That's what we're hoping to do with Premium, is to actually start mapping what people have been using to manage depression and drinking problems, but on a broader level, to develop a methodology that allows us then to apply that to any other mental health condition, whether it's child behavior problems or any other kind of mental health condition. There are some tantalizing possibilities, obviously. South Asia has a rich meditation history. There could be things that have that emerged over thousands of years from the meditation tradition that could be, because we're also still keeping a very a close watch on the fact that the treatment must be deliverable in a routine setting by a non-specialist worker. So you can't expect a very complicated meditative intervention that requires you to go away and disappear in the mountains for 6 months. It has to be a little bit more practical. So I think we have to sort of weigh out each of these different approaches according to certain sets of criteria, of which scalability is by far the most important before we then evaluate the effectiveness. So that's part of what my work will be for the next few years. But I suspect that something around the meditation strand might emerge as being quite relevant. Your second question was about symptoms of psychosis being culturally valued. There's no question they are, but it depends very much on the context and the particular circumstance of the individual. I do not believe the vast majority of people with psychosis have positively valued experiences. Some do. For example, those who grow up in families where there's a history of traditional shaman-style interventions. So for them, this is a very valued skill. But if you don't grow up in such a family and you started hearing voices, etc., it may in fact be a very bad sign. It might be, just the same explanation can be used in a very negative way, that you're bewitched or you've done something terrible in your past life or whatever. So I don't want to romanticize cultural explanations. They're important to take into account, but I know you're not suggesting this, but they should never be seen as a reason not to do anything. You know, that because the culture values hearing voices in some people, therefore hearing voices is not an impediment to other people.
One more question? Yes.
I find, sorry, me?
Yep.
Okay, thank you for coming. I find that in my religious community, people often expect the religious leaders or people who are believed to have a lot of religious knowledge to solve their mental health problems. Although they don't call it mental health, but that's kind of what I think it is. And I was wondering, in your late health models, how do you adapt the therapies to make it easier for people to accept that they're very religious in terms of treatment?
So we encourage people who are very religious to take up faith-based interventions. That's one example of innovation that is culturally appropriate. So we do not see any conflict at all between faith-based treatments and biomedical treatments. In fact, it's something we would encourage. I think the idea is that, and this is one of the universal elements, I think, that applies across all interpersonal healthcare interventions, giving hope, which is a central element of all psychotherapy, and that the more you believe what we sometimes dismiss as a placebo effect, which I think is something we need to learn to harness, the more you believe that something is going to help you, the more likely you are to actually it helping you. If you extend that argument that we use very often in psychotherapy by giving people hope to faith, then you can see quickly why, in fact, for people who have a religious orientation and believe in a particular faith, faith-based interventions can be very valuable. I think that's why traditional medicine survives so well. It's mostly about faith.
So Vikram, let me say on behalf of everyone here, first, thank you for coming. Also that I can tell from looking at the audience that people have been very inspired. You are truly breaking ground in a very critical area, and I want to wish you really all the best, and I hope everyone here in the audience is going to join you in this movement. I hope you'll get a few minutes of time in the UN in September. The latest I heard was this big so-called UN meeting, although I'm not sure how big it's going to be, may not include mental health. Maybe that's good, maybe that's bad, depending on how the meeting goes. But be that as it may, I think that you are onto something that is, particularly for the students here, a really groundbreaking path. Very inspirational, very important, very critical to the lives of millions of people. So I just want to really again say that we are really happy you came and shared your thoughts with us, and look forward to being with you tomorrow. Thank you very much.
Thanks, Mike.